We're going to get started here. My name's Steven Siegel. I'm a general foregut surgeon down in Orlando, Florida, part of the American Foregut Society, and we're continuing to push forward with our webinar series. We've moved on from GERD and reflux disease, and we're working on to achalasia. Similar to reflux, we're going to split the talk into two different sessions. The first session tonight, which is on diagnostics, and the subsequent session will be on therapeutics for achalasia. So I'm going to start by introducing our moderator. We have two additional speakers tonight. Our moderator tonight is going to be Dr. Nandipati, who's a MIS trained surgeon out of Emory, who's now a professor of surgery at Clayton University, where he serves as the Associate Program Director of Surgery Residency, as well as the Director of the Esophageal Center. His expertise are redo fundoplications, esophagectomies, Poem and Heller myotomies, and obviously achalasia. He's co-authored nearly 60 peer-reviewed papers and over 100 abstracts, and he's a member of multiple surgical societies, including the ACS, SSAT, the ASMBS, and of course, the American Foregut Society. So I'll pass it on to him, who will introduce our speakers and the format for tonight.
Thanks, Dr. Siegel. It is really a pleasure to be here, and I appreciate both speakers being here and willing to present and discuss about one of the complex topics today. As a part of topic discussion, we have Dr. Rena Yalapati. She's going to be first presenter, and Dr. Stephen Clayton, who will be our second presenter. We're hoping that each will stay in their time zone. Each has 20 minutes, and we will keep at least 20 minutes for audience questions and scenario discussions. So first of all, we'll start with Dr. Yalapati. As a lot of you know, she has presented in multiple meetings and national conferences. She is associate professor at UC San Diego, and she currently serves as a medical director of Center for Esophageal Diseases. She has expertise in interpreting esophageal manometry, reflux monitoring, and FLEP. And she has been in the panel discussions for many sessions, including the GERD. And as you all know, she is the co-author, our main author for our current presentation, which is Chicago Classification version 4. With being said that, I will give the podium to Dr. Yalapati. Please see if you can share your screen and take it over from here. Thank you.
Wonderful. Thank you, Dr. Nandipati, and thanks to the AFS for the invitation to speak today. Can I get a thumbs up? Are my slides showing okay? We're good? Okay, wonderful. Well, so my talk is going to focus on Chicago classification and the most recent update. We'll definitely talk about achalasia, but I also wanted to take a chance and talk about the general updates in Chicago classification. And with that, I'll go ahead and start. These are my disclosures. So before we dive into the update in 4.0, I think it's important to take a step back and think about the history of how Chicago classification came to be. We all know that in the early 2000s, there was a great transformation in manometry, where we went from conventional line tracings to high resolution esophageal pressure topography. Much of this work was pioneered by Ray E. Klaus at Washington University. And what ensued was, with this transformation, many groups began adopting manometry, but using it and interpreting it in different ways. And when you talk with experts around that time, they often liken the field to the Tower of Babel story from Genesis, where God had given humans different tongues, and it impeded their ability to speak with one another and make progress. So, this was viewed as a big problem in the field. And in 2007, 3 individuals, this was Mark Fox, Arjan Bredenord, and John Pandolfino, convened and decided to develop an international group to work together and eliminate these competitive factions. So this led to the first version of Chicago classification that was published in 2009. Over the years, there were 2 other updates, one in 2011, the second one in 2015. And it's really led us to where we are today, where now the Chicago classification is the quintessential classification scheme of esophageal manometry. It's used worldwide to identify and categorize esophageal motor pathology. And it's facilitated a tremendous amount of collaboration and innovation, both in the clinical spectrum and also in terms of research. So when we all met in 2019, a little over 2 years ago, there was unanimous agreement amongst the working group that we were in need of an update, and that's what led to 4.0. So, I just want to review a few of the key priorities that were incorporated in Chicago Classification 4.0, and then we'll dive into the details. One of our priorities was recognizing that now Chicago Classification is used worldwide, thousands of individuals in motility labs. We really wanted the update to be generalizable and representative across the world. So actually the Federation of Neurogastroenterology and Motility tasked 7 international societies to elect members. And this is what led to our 52 expert working group, represented 20 countries and 5 continents, so it was quite remarkable. Another priority was we wanted to move away from this sense that there was a small group of individuals that, based on expert consensus, developed the classification, and wanted to move more towards rigorous methodology as evidence-based as possible to develop recommendations that are agreed upon by a wide group. So in order to do this, we applied 2 methodologies in this process. One was the RAND UCLA appropriateness method, and then also the grade method, whenever we were able to utilize it, if there was sufficient literature, was also applied. Now, a very big priority was to develop a standardized protocol for how we use HRM. And this was really the first time that a standardized recommended protocol was going to be introduced. And we felt this was very important as a starting place so that we are all speaking that same language. And then finally, the 4th priority was based on the fact that historically, Chicago classification has been a way to interpret patterns on esophageal manometry. But we know that not all patterns equate to pathology or require action. And so part of 4.0 was to incorporate clinical considerations that would be important to guide treatment decisions. So before we started, we had several surveys to understand where are the priorities going to be for our subgroups in this process. And there were 7 priority areas, as you can see here. Each one was chaired by 2 individuals, and then there was a subgroup within each of these priority areas. And we'll touch on all of these in the talk today. So I'll start with the protocol. So now in Chicago 4.0, there is flexibility that, the protocol can start in either a supine or an upright position, but it does recommend that both positions are utilized. So if you were to start in the supine position, the recommendation is that first there's a 60-second adaptation period. And then the patient is recommended to take 3 deep breaths, and that's to confirm the catheter placement, ensure that the catheter tip has traversed the crural diaphragm. Then there's a 30-second baseline period. And during this time, we can identify landmarks, assess the EEJ morphology, including the EEJ contractile integral, intragastric pressure, baseline EEJ pressure. Then starts the test swallows with 10 5-milliliter wet swallows. And again, this could also be in the upright position. And then following the 10 swallows is the multiple rapid swallow. And this could be 1 to 3 sequences. And we'll touch on this a little bit more later, but generally the MRS sequence is 2 milliliters successively with 5 swallows. And during that time, in a normal response, we see lack of peristaltic activity in the esophageal body, the LES relaxes, and then is followed by augmentation of contractility. Now, following the supine position, the patient can be moved to the upright position. And again, there is that adaptation period, 3 deep breaths, and then a 30-second baseline phase, followed by 5 wet swallows in the upright position, and then a rapid drink challenge. And the rapid drink challenge is where a large volume, about 200 cc's of water, is ingested rapidly. And in a normal response, you will see absence of peristaltic activity, again, in the esophageal body, relaxation across the LES. And if you have impedance, you can also measure clearance. Now, I did want to just touch on the metrics and thresholds in 4.0. So these were largely unchanged, but there were some nuances and some details that were incorporated into 4.0. So first of all, the IRP is still that hallmark metric of relaxation across the LES. But it's very important to note that the IRP can differ in terms of a normative threshold, depending on what manometry system you're using, what position the patient is in, and what maneuver is being administered. So very important to know your system, or if you're looking at a patient's report from outside, know what system was used and know what thresholds apply. Now, in terms of peristalsis, still the distal contractile integral is the metric of contractile vigor, and the thresholds are the same as in prior iterations, where normal is between 450 to 8,000, and then weak is below 450, failed being 0 to 100, and then over 8,000 is hypercontractile. And then the contractile wavefront integrity is measured by the isobaric contour of 20 millimeters mercury, and a peristaltic break is when there's a break of 5 centimeters or greater. It's important to know that now peristaltic breaks are encompassed under an ineffective swallow. And then the distal latency still remains the metric to measure latency of deglutitive inhibition with the threshold of 4.5 seconds. And then you'll also note that there was more emphasis on pressurization, both pan-esophageal pressurization and also intrabolus pressurization. Okay, so this is the hallmark classification scheme of 4.0. And what it does is it incorporates in the recommended protocol along with the hierarchical classification scheme. So if we start with this and start at step 1, where we're performing 10 wet swallows in either the supine or upright position, if your patient has an abnormal or an elevated median IRP, and 100% of the swallows are either failed or premature, you're going to consider a diagnosis of achalasia. Now, the majority of the manometric definitions for achalasia were largely unchanged, and it's really stood the test of time, where type 1 is akin to our classic achalasia, where the median IRP is elevated and 100% of peristalsis is failed. And then type 2, like type 1, but 20% or more of swallows will have that pan-esophageal pressurization, which we're seeing here under an isobaric contour of 30 millimeters mercury. And then type 3 is akin to our spastic achalasia, where the median IRP is also elevated, but 20% or more of swallows are spastic. Again, that being a distal latency less than 4.5 seconds. And an important update in 4.0 was the specification that all other swallows, if they're not spastic, must be failed to meet a criteria for type 3 achalasia. If there is peristaltic activity, that might be more akin to EEJ outflow obstruction with spastic features. Also important to note that type 3 achalasia pattern can be seen in the setting of opioid use. And so it's important to note that, ask about it in the clinical history, try to test off of it if it's possible. Definitely recommend getting off of opioids if you do diagnose type 3 achalasia in the setting of opioid use. Now, we also recognize that patterns on manometry don't always fit that cookie cutter pattern of type 1 or type 2, and there are some scenarios that might be inconclusive. For instance, one that's not uncommonly found is when the median IRP is at that upper limit of normal, and otherwise it meets criteria for type 1 achalasia. And this is an example here of that exactly, where the patient then had a time barium esophagram and a flip, which we'll be hearing about in the next talk. And those actually supported a diagnosis of achalasia. So if you have an inconclusive pattern, the recommendation is to proceed with supportive testing, which would be a time barium esophagram, ideally with a tablet and or a flip. Okay, so if we come back to the classification scheme and the IRP is elevated, but doesn't really meet criteria for achalasia, then you'll want to consider if your patient has a diagnosis of EEJ outflow obstruction. And EEJ outflow obstruction was probably the top priority of update in 4.0. The reason being that since EEJ outflow obstruction was introduced as a manometric disorder, we've found that up to 10% of manometries identify an EEJ outflow obstruction pattern, according to prior definitions. Where it becomes problematic is that up to a third of patients don't have a clinically relevant EEJ outflow obstruction. That IRP might be elevated because of catheter artifact, a mechanical effect, hiatal hernia. And for these patients, it would be inappropriate to treat them as an EEJ outflow obstruction with myotomy and their risks for outcomes. Yet at the same time, a proportion of patients that have manometric EEJ outflow obstruction do have a pattern on the spectrum of achalasia, or they might evolve towards achalasia. So it was very important to try to distinguish between primary LES dysfunction versus other etiologies of manometric EEJ outflow obstruction. So in 4.0, the criteria now for EEJ-00 is that it requires a manometric diagnosis, which is an elevated IRP in both supine and upright positions, and also evidence of intrabolus pressurization. Now, a manometric diagnosis is always going to be considered clinically inconclusive, and it requires clinically relevant symptoms. And these symptoms would be obstructive symptoms, so dysphagia or non-cardiac chest pain. And it also requires corroboration with a supportive test, and that would be either a time barium esophagram or a FLIP. It's also important to note that, when you see EEJ outflow obstruction on manometry, pay attention, of course, to the peristaltic activity in the esophagus, because these probably have different clinical implications. If you have a patient that has EEJ outflow obstruction with spastic features, this might be someone, again, along that spectrum of type 3 achalasia. Whereas if someone has ineffective motility or intact peristalsis, it's very uncommon to have a true LES dysfunction with intact peristalsis. And we recommend particularly a cautious treatment approach for these patients. So, the priority for today was to talk about achalasia, but I did want to take a few minutes and talk about disorders of peristalsis. And when you do your manometry, and if a patient has a normal IRP, and they're presenting with dysphagia or an esophageal symptom suggestive of a motor disorder, you want to consider whether they have a disorder of peristalsis, the first one being absent contractility. So absent contractility also has really stood the test of time. The diagnosis on manometry is a normal IRP and 100% of failed peristalsis. Again, remembering that if you have that borderline normal, upwards normal IRP, consider whether your patient might have achalasia, look to supportive testing, look to the other maneuvers on manometry, like the rapid drink challenge, to see if there are any signs of LES dysfunction. If we keep going down the algorithm here, we also will consider whether a patient has a spastic esophageal disorder. And then this includes distal esophageal spasm and hypercontractile esophagus. So for both of these, the manometric criteria did not change much in 4.0. But for both, we did recognize that we often see these patterns on manometry, but they're not always clinically relevant. For instance, you can have a patient that has heartburn as their primary symptom with a hypercontractile esophagus, and that might be more related to their GERD rather than their primary motor disorder. And so for that reason, in 4.0, it requires the presence of clinically relevant symptoms, again, dysphagia or non-cardiac chest pain, in addition to the manometric criteria to meet conclusive diagnosis. I'll just make a few notes for distal esophageal spasm. Again, the majority of these patterns that we see on manometry may represent a response to reflux in patients that have GERD. And so in these cases, think about whether your patient has GERD. If they do, focus the treatment first on anti-reflux management prior to antispasmodic management. Also keep in mind that opioids can lead to a distal esophageal spasm pattern, and for these patients would recommend opioid cessation. And then true distal esophageal spasm is really a rare finding, but when we do see it, it probably is along the spectrum of type 3 achalasia, and they often do well with similar treatment approaches also. Just a couple notes about hypercontractile esophagus. So in 4.0, there was a change now where hypercontractile esophagus is not synonymous with jackhammer esophagus, but rather we recognize that there are different presentations of hypercontractile, where you could have a patient that has a single peak hypercontractile swallow, someone that has the jackhammer pattern with repetitive prolonged contractions, or this new entity that's been described, which is a hypercontractile LES. So recognizing that there is heterogeneity, and also that many of these might reflect, again, a response to reflux and not always a primary pathology, we recommend a cautious approach in terms of treating contractile vigor as an endpoint. And then finally, is the consideration of whether your patient might have ineffective esophageal motility. And there were updates to IEM. The definition is more stringent now. So a conclusive diagnosis of IEM requires that more than 70% of the swallows are ineffective. And this could be a weak swallow, failed swallow, or fragmented. Or if at least 50% of the swallows are failed, that also meets the diagnosis of IEM. And so again, IEM now encompasses fragmented peristalsis. If you have a patient that's in the borderline, 50 to 70% are ineffective, look to supportive testing. You can look to impedance on manometry, the multiple rapid swallow, or barium esophagram, and these might strengthen your confidence to or against the diagnosis. And then finally, if you're gone through the algorithm and there's no evidence of a disordered peristalsis or outflow obstruction, either your patient has normal motility, you can consider postprandial testing if you want to evaluate for rumination or supragastric belching. You can also look to other maneuvers, solid test swallows, pharmacologic provocation if you have it available, to look for obstruction if you highly suspect that there is an EEJ outflow obstruction, but it wasn't detected on the standard protocol. And so when we think about where we were and where we are now, Chicago classification is really that quintessential classification scheme of esophageal motility patterns, and has really standardized our interpretation and terminology worldwide. In terms of 4.0, I think the important updates and takeaways are that there is now a standardized manometry protocol. Chicago 4.0 refines the definition of EEJ outflow obstruction and IEM, and incorporates clinical context and relevance for particular manometric patterns, particularly EEJ outflow obstruction, distal esophageal spasm, and hypercontractile esophagus. And Chicago classification is an iterative process that's prone to evolution, and already we're planning for 5.0, and we anticipate that we will have more data to be able to better phenotype patients with spastic esophageal disorders, to incorporate impedance. That's something that we had wanted to do with 4.0, but we weren't quite there yet. But many groups are studying impedance in the role of high resolution manometry. And then there's also a lot of exciting work being done with physics-based modeling and artificial intelligence. So with that, I also want to thank our incredible working group. It was 52 members strong, and much of our work was during the pandemic. And it was really incredible for everyone to come together across several time zones across the world, but none of it would have been possible without this incredible group, and is really a testament to collaboration. And with that, I will end. I look forward to the Q&A panel session at the end of this. And I do want to make just one little plug that next Friday at UC San Diego, we have a symposium on the frontier of esophageal diseases and motility. So if anyone is interested, feel free to email me or reach out. It's free registration, and it is CME. Anyways, thank you so much for this, and I'll stop sharing now.
Thank you, Dr. Yalapati. That was a really outstanding summary of the Chicago 4.0, and we're really looking forward for questions in the chat box. Please, audience, if you have any questions, type in the chat box. I will collect all of those and then ask the presenters at the end. Because of the time constraints, and also thank you for staying in time limit of your 20 minutes. Now I would like to introduce our second presenter, that is Dr. Stephen Clayton. He's an assistant professor at Wake Forest University, and he's in the Department of Gastroenterology. He did his fellowship at the University of South Carolina, and then also he has done a swallowing double fellowship in South Florida. And you can see from his CV itself, he has an outstanding interest in swallowing and research activities in dysphagia and reflux disease. He's also interested in extraesophageal manifestations of GERD, achalasia, and eosinophilic esophagitis. Today, Dr. Clayton is going to talk to us about EndoFlip technology, as many centers is upcoming are still learning about this technology. I'm also really looking forward to learn a little bit tips from Dr. Clayton. With that, Dr. Clayton, please take it away, please.
Thank you for that wonderful introduction, Cal. We'll see if we can overcome the technical difficulties we were having earlier.
My name is Stephen Clayton. I'm Assistant Professor of Medicine at Wake Forest University Baptist Medical Center. I'd like to thank the American Foregut Society for the opportunity to talk with you tonight about tonight's topic, diagnostic approach and intraoperative usage of the functional lumen imaging probe, or the FLIP, in the management of achalasia. I have no pertinent disclosures or conflicts of interest. Tonight's discussion objectives: to provide a brief overview of what the FLIP is, the science and metrics associated with the FLIP, how FLIP is performed and its normative values. We will discuss the importance of FLIP in the diagnosis and subtyping of achalasia. We will discuss its intraprocedural and intraoperative usage in the treatment of achalasia. We will discuss FLIP's role in the long-term management of achalasia, especially after lower esophageal sphincter intervention. We will discuss some of the limitations of FLIP and future directions. So what is the FLIP? Well, simply put, the FLIP is a device that measures luminal cross-sectional area and pressure in the esophagus using impedance planimetry, allowing for the measurement of dissensibility. The FLIP hardware includes a catheter with a highly compliant balloon. Within the balloon, there are 16 paired impedance planimetry electrodes and a solid-state pressure transducer located distally. The FLIP catheter is available in two sizes, an 8 centimeter and a 16 centimeter catheter. The computer software converts the impedance recordings to cross-sectional area measurements along the length of the catheter and creates a three-dimensional rendering of the esophageal lumen. With the 16 centimeter catheter, a second monitor will display a topographic representation of the esophageal lumen diameter in real time, allowing for visualization of esophageal contractile patterns. I'd like to have an understanding of the physics behind a new technology like FLIP to understand how it provides meaningful clinical information about physiology. The FLIP uses an ingenious extrapolation of Ohm's law to calculate cross-sectional area. Using Ohm's law, voltage equals current times resistance. Resistance, which is equivalent to impedance, can be expressed as the distance between electrodes divided by fluid conductivity times. Thus, the cross-sectional area can be calculated by measuring the voltage across paired electrodes spaced at a known distance as the balloon is filled with a fluid of known conductivity, in the case of FLIP, saline, while excitation electrodes at the other end of the balloon emit a continuous low electrical current. Finally, assuming a circular lumen, the cross-sectional area can be converted to a diameter to aid in clinical interpretation and application. And finally, by applying Laplace's law, the esophageal lumen distensibility can be calculated from the cross-sectional area and the balloon pressure data. Therefore, FLIP can characterize the properties of the esophagus, including distensibility, compliance, cross-sectional area, and wall stiffness. FLIP can be performed a variety of ways. I recommend endoscopic placement of the FLIP catheter. For my diagnostic work, I typically use the EF322 catheter, which is the 16 centimeter catheter. It has a flexible plastic tip on the distal end of the catheter, which fits perfectly into the suction channel of the adult EGD scope. And then using endoscopic guidance, I typically will place the catheter into the antrum of the stomach. I then inflate the balloon to 30 mLs, and I pull it proximally, watching carefully for the constriction of initially the proximal part of the catheter, and I continue to pull proximally until that waist-like constriction is within the distal 2 to 3 impedance sensor, so that it's kind of straddled between the lower esophageal sphincter and the stomach. Once the catheter position is confirmed, then I basically start filling the balloon with saline. Filling is done in a graded approach and monitored for 60 seconds at each fill. Typically for the EF322 balloon, we recommend 40, 50, 60, and sometimes even 70 ml fills. The typical metrics reported from FLIP are the maximum diameter of the narrowest luminal opening, the cross-sectional area, the intra-balloon pressure. Compliance is calculated by taking the volume 1 centimeter above and 1 centimeter below the narrowest point in the sphincter, and dividing that volume by the distending pressure. Compliance provides information on the ease of stretching within the whole sphincter and not just one point. And finally, dissensibility is calculated by taking the narrowest point of the sphincter and measuring its cross-sectional area and dividing it by the intra-balloon pressure. It is a measure of how easily the narrowest point in the sphincter stretches. Dissensibility is the most common metric mentioned in the literature. With the latest version, version 2 of the EndoFlip software, we discussed that you can get a topographic representation of the contractile patterns. Carlson et al. Initially described these. In slide A on the far left, you can see repetitive anterior grade contractions in a normal swallow. In B, you see reduced dissensibility and a lack of repetitive anterior grade contractions in a patient with esophagogastric junction outflow obstruction with features of ineffective esophageal motility. Bottom left, we see a patient with absent peristalsis and a reduced dissensibility in a type 1 achalasia patient. And on the bottom right, we see reduced dissensibility with repetitive retrograde contractions in a patient with type 3 achalasia. In a recent article published in March of this year, Carlson et al. Further categorized their original descriptions of distension-induced contractility patterns and how they relate to achalasia. Contractions can be further categorized as occluding if they achieved a minimum esophageal diameter of less than 6 millimeters of mercury, or non-occluding if they didn't. When non-propagating occluding contractions were associated with significant pressure increases, typically greater than 35 millimeters of mercury, they were designated sustained occluding contractions. We will discuss the clinical applicability of these different contractile patterns and how they relate to achalasia subtyping in a few slides. Now that we've discussed the science, metrics, and contractile topographic patterns associated with FLIP, we can now shift gears and begin discussing how the FLIP technology complements our other existing diagnostic modalities commonly used in the diagnosis and management of achalasia, these modalities being the barium esophagram and high-resolution manometry. Our example below represents a patient with type 1 achalasia on time barium esophagram, high-resolution manometry, and with the EndoFlip. How does EndoFlip complement our existing diagnostic modalities for achalasia, most notably the high-resolution manometry and barium esophagram? Well, the greatest advantage of FLIP is that it does not require an unsedated intranasal catheter, and this significantly increases patient acceptance. Furthermore, FLIP can be done at the time of EGD and seldom adds more than 8 minutes to the total procedure time. As we all know, the integrated relaxation pressure is an imperfect measure, and therefore high-resolution manometry carries the risk of missing the diagnosis of achalasia, especially in the setting of a normal integrated relaxation pressure. FLIP can be particularly useful in situations characterized by borderline high-resolution manometry findings, but patients with compatible symptoms of achalasia and high clinical suspicion. In 2012, Rohoff et al. demonstrated that esophagogastric junction distensibility is impaired in patients with achalasia. And they found that improving the esophagogastric junction distensibility after therapy basically correlated with clinical success and improved emptying on time-barium esophagram. Their findings suggest that esophagogastric junction distensibility, rather than lower esophageal residual pressure, determines the severity of clinical symptoms in achalasia. Also from the same study, Roeff et al. Examined healthy volunteers with the EndoFlip and recorded their esophagogastric junction distensibility index. They then used the lower 90th percentile of the esophagogastric junction distensibility in healthy volunteers as the normal cutoff value. This is where the normative value for distensibility index being greater than 2.9 came from. Once Roeff et al. Had determined what a normal distensibility index was, they compared esophageal emptying on time-barium esophagram in patients with normal distensibility versus those that had impaired or reduced distensibility. And what they found is that there was improved esophageal emptying in the patients with normal distensibility and barium retention in those that had impaired distensibility. And thus, the esophagogastric junction distensibility index less than 2.9 is associated with a better correlation with impaired esophageal emptying on time-barium esophagram than at borderline integrated relaxation pressure. This was incorporated into the latest Chicago classification scheme, especially in the inconclusive diagnosis of achalasia. Here, you see a high-resolution manometry representative swallow with a borderline IRP of 10.8 and complete aperistalsis. On the right, you see the same patient with the time-barium esophagram with a significant residual column. And on the lower right, you see the functional lumen imaging probe panometry representation, where you see a reduced distensibility index and complete aperistalsis consistent with type 1 achalasia. Once normal distensibility and contractile patterns have been defined, then a classification scheme for dysmotility can be determined. This slide is from the white paper released a few years ago. You can see many similarities with the Chicago classification scheme. For example, reduced distensibility equates into disorders of esophagogastric junction outflow obstruction, and the contractile pattern determines where it would fall in the classification. Some examples would be in a patient with reduced distensibility with repetitive anterior grade contractions. This would be similar to clinically relevant esophagogastric junction outflow obstruction on manometry. Another example would be a reduced distensibility index with repetitive retrograde contractions. This would be similar to a type 3 achalasia. And reduced distensibility with absent peristalsis can be seen in both type 1 and type 2 achalasia. As I alluded to earlier, in a recent article from Carlson et al., they described the new distension-induced contractility patterns and how these new patterns could be helpful in distinguishing between the three achalasia subtypes. Using a series of decision trees, flip panometry was performed in 180 patients. And they found that flip panometry with a 60 ml balloon fill with a balloon pressure less than 21 millimeters of mercury, an absent contractile response was predictive of type 1 achalasia. Type 2 achalasia was predicted by a 60 ml balloon fill, an intraballoon pressure between 21 and 34 millimeters of mercury, and an absent contractile response or an intraballoon pressure greater than or equal to 34 millimeters of mercury without occluding contractions, repetitive retrograde contractions, or sustained occluding contractions. Type 3 achalasia was predicted by a 60 ml intraballoon pressure greater than 46 in the presence of occluding contractions, presence of repetitive retrograde contractions, and the presence of sustained occluding contractions. Using this decision tree model, subtypes of achalasia 1, 2, and 3 were identified with 71 and 55% accuracy in the trained and test cohorts, respectively. As we all know, in most circumstances, differentiating type 3 achalasia from the two other types is of clinical importance because We all know that patients with type 3 achalasia, for the most part, do better with POEM versus other achalasia therapies. In this regard, they were able to accurately differentiate high-resolution manometry classified non-spastic from spastic esophageal dysmotility with 90% and 78% accuracy. The most common indication for FLIP in my practice is in the evaluation of clinically relevant esophagogastric junction outflow obstruction. While a proportion of patients with esophagogastric junction outflow obstruction may evolve into achalasia or have an achalasia variant, many cases are clinically irrelevant, as the IRP can be artifactually elevated by the presence of an obstructing process in the esophageal lumen, opioid use, or artifactually elevated as a result of a hiatal hernia. In an effort to diminish overcalling esophagogastric junction outflow obstruction and limiting the amount of clinically irrelevant diagnosis, the latest version of the Chicago classification scheme has refined the manometric diagnosis of esophagogastric junction outflow obstruction. Now, the median IRP has to be elevated in the supine and secondary position. And greater than 20% of swallows need to be associated with an elevated intrabolus pressure, and the patient has to have clinically relevant symptoms. For a clinically relevant conclusive diagnosis of esophagogastric junction outflow obstruction to be made, it has to be supported with one of the following supportive investigations: either delayed esophageal emptying on time barium esophagram, or reduced dissensibility with preserved peristalsis on FLIP panometry. Below is an example of a patient with clinically relevant conclusive diagnosis of esophagogastric junction outflow obstruction. On manometry, on this representative swallow, they have preserved peristalsis, an elevated intrabolus pressure, and an elevated IRP. They have delayed esophageal emptying on time barium esophagram and reduced dissensibility with repetitive anterior grade contractions on FLIP panometry. Now that we've discussed normal values in terms of distensibility and where they've come from, as well as the different contractile patterns associated and seen commonly on FLIP, we'll talk about the clinical utility of intra-procedural and intraoperative FLIP usage. And this is perhaps the greatest clinical utility of the FLIP system. FLIP provides real-time objective feedback during a surgery or procedure. It's a point of care and can be done either in the endoscopy suite or the operating room. And not only is this applicable to achalasia, however, FLIP can provide guidance in the entire gambit of foregut pathologies and interventions. Reviewing the literature, there is some variability on procedural and intraoperative FLIP performance. However, some consensus guidelines are trying to standardize that as of this year. FLIP has shown some clinical applicability in predicting the outcomes of pneumatic dilation. In particular, which patients would have immediate clinical response versus those that would be non-responders. In a study of 54 patients, 29 of which were treatment naive, who underwent pneumatic dilation as their primary therapy, they found that patients that had a lower baseline dissensibility index were more likely to have immediate response. They found no difference in the post-dissensibility index between non-responders and responders. In the immediate responders, pneumatic dilation significantly changed within the subject and had a significant increase in distensibility. However, not surprisingly, in immediate non-responders, the distensibility index was unchanged by pneumatic dilation. As previously mentioned, there's been considerable variability on how intraoperative or intraprocedural FLIP is performed. This year, there was consensus guidelines released in an effort to hopefully standardize how intraoperative FLIP is done in different procedures. According to this consensus guidelines by Su et al., they recommended for the per-oral endoscopic myotomy or POEM procedure, they recommended that the intraoperative endoflip be performed with an 8-centimeter balloon. They recommended obtaining measurements at a balloon fill of 40 mLs. They recommended that the patient be flat and to hold positive pressure ventilation at the end of expiration while obtaining the measurements. After creation of a submucosal tunnel, they recommended placing the flipped catheter endoscopically to diminish the risk of perforation. A recent study looking at intraoperative POEM found clinically significant symptom improvement greater than 12 months out post-operatively in patients that underwent an intraoperative flip, where basically if the Dissensibility index was less than 2.9, the myotomy was extended. However, there was no significant difference between retained barium on time barium esophagram, post-procedure esophagitis, or distal esophageal acid exposure time measured by pH impedance, and there was no significance in the post-POEM IRP. This is a slide from the previously mentioned consensus guidelines published this year by Su et al. And it summarizes the 5 major intraoperative flip studies that have been done with POEM to date. And I want to just kind of take this time to highlight some of the major takeaway points. Titobaum et al. Described an ideal final dissensibility index range from 4.5 to 8.5 using a 40 milliliter balloon fill for patients who have undergone both laparoscopic myotomy and POEM. They found that a final dissensibility index within this range produced the best symptomatic outcomes with regard to low Eckert and GERD-Q scores. Now, forgive me, I'm probably going to pronounce this incorrectly, but I'm going to give it my best shot. Na Gem Room Fong et al. Performed a retrospective multi-center study of 63 patients who underwent POEM using a 30 ml volume fill. And what they found is the patients with reflux esophagitis had a larger final cross-sectional area and minimal diameter compared to those without reflux esophagitis. For cross-sectional area, it was 99.5 versus 79 millimeters squared. And finally, Su et al. Performed a single-center retrospective study of 77 patients who had also underwent either laparoscopic myotomy or POEM, and they found that patients with a final postoperative Eckert score of greater than or equal to 3 were more likely to have a final dissensibility index of less than or equal to 3.1. And additionally, they also found similar findings to the previous study mentioned, that when the cross-sectional area was elevated or the maximal minimal diameter was elevated, this was a predictor of worse reflux at 2 years based upon reflux index scores. In this same consensus paper, they proposed a standardized method of performing intraoperative flip during laparoscopic myotomy. They recommended the use of the 8 centimeter balloon with a 40 milliliter fill. They recommended obtaining flip after crural dissection, myotomy, fundoplication, if applicable. They also recommended after the myotomy that the catheter should be placed endoscopically to prevent perforation. They recommended that the flip be performed in reverse Trendelenburg. They also recommended to hold positive pressure ventilation at the end of expiration. They recommended flip be performed after the release of insufflation with no pneumoperitoneum. Helder myotomy for achalasia demonstrates some interesting distinct changes in the dissensibility index, characteristics of the esophagogastric junction at various phases of the procedure. In this study from DeHaan et al., Helder myotomy resulted in a 4 to 5 fold increase in the dissensibility index of the esophagogastric junction in patients with achalasia. The addition of the fundoplication resulted in a decrease in the dissensibility index, but the final dissensibility index was still significantly higher than the pre-myotomy dissensibility index in this study. Flip is very useful in the long-term management of achalasia. As we all know, the long-term management of achalasia is challenging at best, especially as treatment declines over the long term. Symptoms are often unreliable, or patients may have impaired esophageal sensitivity, patients get used to their symptoms or adapt their diet. FLIP is an important tool in the objective evaluation of achalasia patients post-treatment and complements the time period esophagram in this regard. So in a patient with recurrent symptoms, it would be useful to perform FLIP and measure their post-intervention distensibility index and look for a reduction. As previously discussed, there are many advantages of the FLIP technology over traditional manometry and radiographic studies. However, FLIP is not perfect. There are some limitations. First of all, primary peristalsis and secondary distension-induced peristalsis are different entities. Secondary peristalsis is not always elicited with balloon volume distension, and therefore, with the FLIP technology, there may be a preponderance to overdiagnose achalasia or disorders of absent peristalsis. FLIP may not be as useful as traditional high-resolution manometry in disorders of hypomotility, such as ineffective esophageal motility, and there may be a tremendous amount of inter- and intra-observer variability in interpreting the FLIP studies. So here is a good example of one of the limitations of FLIP from my endoscopy day on Monday. On the left, you see a FLIP panometric tracing that shows or demonstrates reduced distensibility of the LES and absent peristalsis. This was present on all volume balloon fills, including 40, 50, and 60 milliliter balloon fills. We tried various different maneuvers to elicit secondary peristalsis, including pulling the FLIP catheter more proximal into the esophageal body, but we were never able to elicit secondary peristalsis. On the right is a representative swallow from the same patient on high-resolution manometry. And albeit it's ineffective, the DCI is less than 450, there is intact, inadequate peristalsis. So this just kind of illustrates the point that primary and secondary peristalsis may be different entities. In summary, FLIP complements traditional achalasia diagnostic modalities. Reduced distensibility index is associated with disorders of esophagogastric junction outflow obstruction. Topographic contractile pattern assists with subtyping achalasia. An intraoperative distensibility index in the range of 4.5 to 8 is associated with improved achalasia symptoms with lower levels of symptomatic GERD. And a cross-sectional area post-LES intervention greater than 95 millimeters squared has been correlated with post-LES intervention GERD. Future directions. One would be the standardization of the performance of FLIP intraoperatively. Two, defining those intraoperative FLIP values that we should strive for in the treatment of achalasia that improves achalasia symptoms but limits post-lower esophageal sphincter intervention GERD. And finally, perhaps one day we'll develop a non-intranasal catheter system to evaluate esophageal motility. This concludes my presentation. I once again would like to thank you for your time and attention, and I would like to thank the American Foregut Society for the opportunity to present on this topic today. Thank you very much.
Thank you, Dr. Clayton. That was an outstanding summary of the FLIP literature so far. I'd like to thank Dr. Yalapati, who's answering some of the questions as we go by in the chat box as she has to leave. I know some of the questions has been answered. I will try to see if we can catch a few more questions from her before she leaves. One is, how long do you stop opioids for manometry or prior to manometry in patients who are on chronic opioid therapy? And if they are not willing to stop or not want to stop, do you do anything different?
Yeah, thank you. Yeah, this question has come up a lot since 4.0 was released. So, the general recommendation is that if they're able to get off of opioids and test off, that's ideal. The recommendation would be based on the half-life of that specific opioid. So it would depend opioid to opioid, but a lot of patients aren't able to, and that's perfectly okay as long as when you're interpreting it, you include the context that this is on opioids and it may reflect opioid-induced dysmotility. And I think the primary point is really counseling patients that they can have reversal or improvement of their peristalsis if they stop their opioids, if you do detect a disorder.
I think you're going to kill 20% of our practice, Dr. Yalapati, if you start telling patients to stop opiates right away. That's a difficult one, but I think that point is very valid, that you should explain to the patients and also referring physicians sometimes opiates can have a significant impact on the mortality. One more question before you go. You mentioned about pharmacological provocation in EEJ outflow obstruction sometimes. What do you use and how do you administer it?
Great question. So this is it's very interesting, and there have been a couple investigators that have published on amyl nitrate and CCK and administering these in the lab and assessing for reductions in IRP. And you can identify EEJ outflow obstruction or achalasia, particularly in inconclusive cases. I will say that I don't know of many labs that have pharmacologic provocation available. And so in our lab, we don't. Our motility nurses perform the manometry procedures. So we don't use AN or CCK, but there are a few labs around, at least the US, that do. In those cases, I think the providers are typically present for the procedure, and I've heard of both being used.
Yeah. I think we have very least experience in it. So I think that's probably a hard one for CCK. Sometimes even in the OR itself, to get the CCK is not always easy. And nitroglycerin might be a hard sell from anesthesia. But I think with the availability of other technologies, I think we can be, depend on the other things that you mentioned. One last question is, given the significant amount of time it takes for version 4, there might be a change in the RVU reimbursement in the future, which I think it is very doubtful, but what do you think?
Yeah, I don't know if that will happen. And I agree that I doubt that, but I do want to emphasize that what we recommended as the standard protocol is kind of the optimal protocol. And every lab, they need to decide what works for them in accordance to how much time is allotted, who's performing the procedure. And we did recommend that there's flexibility in all of that. And but I will say that we've incorporated the new protocol a year ago, and it adds a total, the whole protocol is 15 minutes, and it adds an additional 5 minutes to our prior protocol. So it really, once you get used to it, it actually does not add that much more time. Sure.
Yeah, I doubt the RVUs are going to go up the way the healthcare system is going. One more last question before you leave is, what are your thoughts on manometry shows that may be showing early achalasia in progress? Example, study showing elevated IRP with the 20% pan-esophageal pressurization, but may only have 70 to 80% of total swallows failed. How do you take, and we also see sometimes this early or inconclusive achalasia or incompletely expressed achalasia. What do you do in those situations?
Yeah. So first of all, I always make sure that I have excluded mechanical causes of obstruction, because when there's this mixed pattern, you want to assess for that mechanical obstruction. And also, if there has been rapid weight loss or there's any concern for a pericardial mass or etiology, looking for that. But otherwise, I treat it like we would now EEJ outflow obstruction. And so I will look to my supportive tests. But if there's reasonable evidence that there is outflow obstruction and there's a variant towards achalasia, depending on the patient's comorbidities and age, we might recommend intervention, particularly if they're younger and it's very much consistent with achalasia.
Yeah. And what about your MRS? Do you see any difference between upright or supine? Is that being studied at all? And I think a lot of patients complain about coughing and with the MRS.
Yeah, absolutely. So the most studies that have been done have been in the supine position, and that's where most of the data comes from. And so for that reason, it was included as a supine MRS in the protocol. With that said, if a patient has achalasia, clear-cut achalasia, many of them can't tolerate these provocative maneuvers, RDC, MRS, and so we will abort the procedure. Sometimes we'll only do 10 supine swallows and clear-cut achalasia. So, in those cases, I think it depends on a case-by-case basis.
Very good. We appreciate you presenting, and I know you have to attend another
Yeah,
meeting. Thank you.
No, thank you
All
so
the
much
best.
for allowing me to answer these questions. I'm going to jump off, but thank you to everyone and have a great day.
Dr. Clayton, we have some of the questions from the panel and also from the attendees. First of all, you said that you want to, or you actually recommend placing endoflip catheter via endoscopy. Have you noticed any damage to the balloon or any issues while placing? Because it seems like majority of the reps, even the rep that came to us, was really warning me while I was placing that way. So we kind of moved on to placing blindly and then doing endoscopy by the side. So which one is the best method, you think?
Can you hear me okay?
Yeah, absolutely.
I've placed 100% endoscopically. We've not had any complications or catheter damage. It's very easy. They have an ingenious design where it fits, the little plastic piece fits right into the suction port. You just drive it down into the stomach. And then you can, use the endoscope as a secondary method to confirm placement so that you know exactly where the balloon's at, so you don't get erroneous measurements.
Mm-hmm. And what would be the scenario where you'll use 70 ml flip volume at all? Because majority of the recommendations are at 40, 50, and 60. Where do you see the value of 70 ml in some cases?
There would be two scenarios that I would use a 70 ml fill. First, you want to get a intraballoon pressure greater than 15. So if for some reason you had a significantly dilated esophagus, to adequately measure distension, you've got to get that balloon volume above 15. That, I don't think I've ever seen that scenario happen, but that would be one scenario that you would do it for. Secondary, if you're really trying to elicit secondary peristalsis, or you're trying to discern whether there's truly a reduced distensibility index, it's going to be a little bit more sensitive at the higher balloon volume. So if you see you have a borderline distensibility index, you're trying to figure out if this patient truly has a disorder of esophagogastric junction outflow obstruction or it's some sort of artifact. But once again, that's something that we rarely do.
And on the lines of EEJ outflow obstruction, can you elaborate a little bit from the audience want to listen about how do you go in the diagnostic algorithm? Where do you use the flip and when do you use it preoperatively in EEJ outflow obstruction, especially after manometry?
Like I mentioned in the slides, that is the most common indication for flip in my practice. I'm doing 2 or 3 of those probably in every endoscopic session. So as mentioned by the new Chicago classification 4, to get a clinically relevant conclusive diagnosis, you have to have, the supportive tests that support, delayed esophageal emptying or reduced distensibility. I've gotten into commonplace of doing both, doing the time barium esophagram and the endoflip. And if you have reduced distensibility and preserved peristalsis, and then you have a retained barium column, plus the manometric findings of a diminished median IRP with preserved peristalsis and symptoms of dysphagia, those are the patients that I'm going to do an LES intervention on.
Well, have you consistently noticed this Achalasia type subclassification and flip? Because we have noticed that it has not been consistently as accurate as diagnosing the EEJ outflow obstruction, even with different volumes. What would be some thoughts and suggestions for us to get a consistent readings on type 2, 3, and 1 Achalasia? Because sometimes we see even with changing the volume, we're not getting that, typical readings that you suggested in your presentation.
That's a good question. My approach to achalasia, mainly because I have all the different diagnostic modalities at my fingertips, is I like to come to the clinical diagnosis much like putting a puzzle together. So if you have a patient with classic achalasia symptoms of, basically voluminous regurgitation, weight loss, dysphagia, you have aperistalsis, and basically elevated IRP on manometry, or you have delayed esophageal emptying on time barium esophagram, and then basically you have a flip that shows a normal distensibility. Well, you've got enough clinical data there to say this patient has achalasia. And you'd want to question whether or not, the balloon was in the right place. Perhaps the balloon, migrated into the stomach and therefore you didn't get an adequate, dissensibility index, or maybe it was in a hiatal hernia sac or something there that may have skewed the dissensibility index. But once again, if you place the catheter, with endoscopic guidance, you have that kind of hourglass-like, pressure reading on the topographic reading. But then you can also have the endoscope there where you can confirm that that balloon actually straddles the esophagogastric junction.
And from your review on the intraoperative usage of EndoFlip, have you seen, do you leave or do you recommend leaving the flip continuously filled during the procedures, or do you deflate? What are the suggestions for the surgeons who are actually trying to do intraoperative EndoFlip?
That was interesting in preparing for this talk. The way they came to that 40 ml number versus the 50 is during using the flip to determine how tight a fundoplication should be. And basically that fill diminishes the risk for catheter injury while the surgeon's performing the procedure in real time. I saw articles saying, both ways, leave it, blown up during the procedure, and that way you can always kind of look at it. And then other people saying, basically to, periodically look at it, for instance, after the preoperatively after the myotomy and then after the fundoplication. I suspect it would be the surgeon's preference.
Yeah, we had a little bit of trouble consistently leaving in the catheter being the pressure recalibration happening during the procedure. So I happen to do right now periodically at the steps that you mentioned. Mm-hmm. That is after hiatal hernia repair, before hiatal hernia repair, that is after the reduction of hiatal hernia, and similar to after the hiatal dissection in achalasia, and then before myotomy, after myotomy, and then after hiatal hernia repair and after fundoplication. In benign cases or esophageal reflux cases, I do similarly just before beginning of the case, and then we disconnect the EndoFlip, keeping it on because the catheter recalibrates. That's been a huge problem for us. Mm-hmm. And then slowly redoing before hiatal hernia repair and after fundoplication. So I agree. I think there might be a surgeon's preference or where you feel comfortable at the end. Both ways can go, actually. It will be interesting to see in the future whether the EndoFlip can predict the failure of myotomy, as some of the articles are showing currently. That would be interesting talk for the future. With that being said, I don't think we have any other questions in the chat box. Let me just check one more last time. I think there is one more question. Let's see. So, Dr. Clayton, how often do you see peristalsis once you achieve 20 millimeters of pressure with distension? Or how long do you wait to see, and how often do you see peristalsis?
This has been kind of a quandary, and we're looking at this, our data here, and hoping to publish our case series. I do think there's a significant discrepancy between primary peristalsis, initiated by conscious swallowing, versus, contractile induced secondary peristalsis. I've had many patients that had completely normal manometries, normal barium esophagograms, that for the life of me cannot elicit a secondary peristalsis with the balloon contraction. So, or with the balloon distension. So I think there's a certain subset that you just have difficulty eliciting the secondary peristalsis. And that's why many of the major guideline societies certainly do not endorse using EndoFlip alone as a way to diagnose achalasia. It has to complement either high resolution manometry or a barium esophagram. Yeah,
I think I agree. I think we are not there as widely utilized and not comfortable at this point yet. One more last question, maybe. Do you do EsoFlip or pneumatic at the same time if you do confirm EEJ outflow obstruction on EndoFlip?
That's a good question. I had considered it because if the EsoFlip balloon, basically you could do the endoflip, the pre-procedure endoflip measurement with the same EsoFlip balloon. What I've done in my practice now is I do a pre-pneumatic endoflip, and then I perform the pneumatic dilation. And then as I go down to inspect my, for perforation after my procedure, I'll just put the endoflip catheter down and do a post-procedure endoflip. But I still do a traditional pneumatic dilation with the Rigiflex balloon. If they made it where I could do the endoflip measurement with the EsoFlip balloon, do the EsoFlip dilation, and then subsequently perform the post-procedure endoflip evaluation, I would probably switch or at least give the EsoFlip a chance. But at this point, I've been using the traditional Rigiflex pneumatic dilation balloon for almost 10 years now, and it's still kind of my hammer for performing pneumatic dilation.
Very good. I think that's still up for personal preference. We do actually use both at different times, endoflip and EsoFlip, alternative-wise.
Yeah,
but that's correct.
And I don't think the EsoFlip comes in a 35 millimeter size. I think it's strictly the 30 millimeter.
Yeah.
So, you certainly, there's a certain patient population where you want to go with a bigger balloon, especially in like the male population. You may want to do your initial pneumatic dilation with a 35 millimeter balloon versus a 30.
Right. Well, I think it was an outstanding session. We'd like to thank you all for presenting, and also I'd like to thank audience for hanging in for the session for entire time. I think that concludes our time because I would like to be conscious of everybody's time. I'd like to thank everyone. And Dr. Siegel, is there anything else you'd like to chime in at the end?
Yeah, I'll just put a plug in for the next planned talk will be on the therapeutic section of achalasia. We look out for the posting. It'll be June 30th, Wednesday, same time, 7 p.m. Eastern. We'll be covering the therapeutics of achalasia. Our speakers will include Marcelo Vela, Robert Moran, Aylin Tanzel, and Mike Ujicki. So keep looking for those advertisements. And I'd like to thank our speakers and our moderator for an awesome session.
Thank you. Thanks for the opportunity for AFS. Thank you.
All right, everyone, take care. Thank you so much.
Thank you.